everyone, and thank you for joining ASCO today for our CHW Learning Community webinar. This webinar is supported through the Health Resources and Services Administration to provide technical assistance on topics related to community health worker certification, financing, stakeholder engagement, and strategic planning. Today's webinar will focus on community health worker integration into care teams. And this webinar includes participants from our 5 learning community states, as well as a select number of other interested states who have also been exploring CHW workforce development. So we look forward to speaking with you all today and to having robust discussion throughout this webinar. And now I will turn it over to Geoff Wilkinson, our subject matter expert, to jump in and introduce the rest of the team. Geoff?
Thank you very much, Anna, and good afternoon, everybody. On behalf of my colleagues, I want to thank ASTHO and HRSA again for the opportunity to participate in this technical assistance project. We had 80 people registered for the webinar as of this morning, so we're clearly embarking on a journey over the next couple of hours that's important for folks all over the country. This is the final of 3 webinars that we've presented for the learning community of 5 states that we've been working with this year. The first webinar on June 16th defined the CHW workforce, and we discussed certification issues and options in some detail. The second webinar on August 2nd examined the value that CHWs bring in healthcare and public health systems and explored financing options in some detail. Today's webinar, as Anna said, will focus on integration of CHWs into care teams and also more broadly into public health and healthcare systems and organizations. We're going to present a conceptual framework for understanding integration and discuss principles and challenges. We're also going to provide practical guidance for state health departments and for providers and other stakeholders. We're fortunate to have Lucia Colindres-Vasquez joining us on the consulting team for this afternoon's discussion. Lucia Advisor of Community Health for Rochester Regional Health in New York, where she coordinates integration of CHWs for this major health system's federally funded district initiative. She's an experienced CHW. She's a CHW trainer and a CHW supervisor, and she's also president of the CHW Association of Rochester. So Lucia can share insights about how health system transformation with CHWs is actually working, and she can get into whatever nuts and bolts may be useful to you. She's also uniquely equipped to underscore a theme that we've emphasized throughout this technical assistance project with your individual states and with the learning community as a whole, and that is that it's critically important to involve CHWs in your policy and program development efforts at every stage. I'm also happy. Yes.
And I'm so sorry to interrupt. It looks like we're having some audio issues. So I was wondering if Rufus, it sounds like there's still some music playing for some of our participants.
It may be a participant who's put the call on hold.
I do apologize.
I had that problem when I was trying to get on. I had to mute it completely.
I think this is a different issue.
Okay.
I do apologize. However, there is no music playing into the conference, and all of the participants' lines are muted.
Okay. I will send out a quick refresher with the speaker dial-in number. Please feel free to use your chat box if the issue is still going on for you all. And again, sorry to interrupt, Geoff.
No problem. I'm sorry for the problems people may be having. I was just going to introduce the other members of the consulting team, and those of you who are in the learning communities are well familiar with Terry Mason, who's an independent policy consultant with a lot of experience in CHW policy and program development based in Boston, and Carl Rush from Texas and research affiliate University of Texas at Houston, and a national expert in CHW workforce development in all aspects. I'm based at the Boston University School of Social Work and have some 15 years in this field. So among us, we're older and more experienced than we'd probably like to admit, and hope that we've been helpful to you as individual states. And we're really looking forward to making this an interactive session with your participation. This is an opportunity to learn from one another as well as with one another. We've got discussion questions embedded into the webinar, and we're going to be glad to stop anytime if you have questions that you would like to ask during our presentation. So with that, let's get into the content. We have 4 objectives for the webinar. One is to provide some context and a framework for talking about CHW integration. 2 is to offer some practical guidance for state health department officials who are our principal audience for this technical assistance, but also to hopefully offer useful guidance for providers and payers who may be participating on the call. We've opened this webinar to states beyond the learning community, and we've opened up this call to stakeholders that are involved with the state health department partners in each of the 5 states. And we'll also provide some examples of integrated CHW programs that we hope will prove useful. Rochester Regional Health is going to be the major example, and we're going to have a good chunk of time with Lucia describing what she's doing and being available for you to ask questions of her and get into. We expect to focus a lot of discussion on how it's actually working in the field. In terms of context, there are a lot of reasons why CHWs are being integrated into healthcare teams and public health systems. First, I think whether you're in a blue state, red state, across the political divides that are so much in the news, there is consensus that our health system is in transformation and needs transformation because we really have persistent challenges involving health equity, the cost of health care, quality, and health outcomes. This is a volatile policy environment. We have some important work going on at the federal level. We also have innovation going on within states and in healthcare organizations. With uncertainty about the fate of the Affordable Care Act, it's really driving innovation at the state and organizational level. So there's growing interest in CHW integration at all levels. That's based in part on the fact that there's been increased demonstration and increased understanding of CHW value in healthcare and public health. And the more people get it in terms of what CHWs are doing across a range of issues, there's increased investment, increased research, increased interest, increased focus on integration. We're also reaching some of the limits of our grant-funded approach to involving CHWs in healthcare systems. So while we have a lot of policy discussion about bringing CHWs into the mainstream of healthcare and public health, we're still basically using a grant-funded, soft money approach to involving CHWs, and that is inadequate. And so there's increased attention into how do we integrate CHWs more effectively at all levels of the system. Just to kind of underscore this, we think that it's fair to talk about approaching a tipping point in terms of interest in and investment in CHWs. Those of you who have participated in our earlier webinars understand that there are no silver bullets to financing CHWs. And so there's been increased interest driven by financing interest in demonstrating CHW value and building a so-called business case for investing in CHWs. And while there are some important initiatives in Medicaid and some important opportunities that we have discussed in previous calls, there's also increased investment in directly by providers using their own core budgets because they understand the cost value, the cost effectiveness, and significantly in a lot of regards, the actual return on investment that CHWs bring, as well as improved health outcomes. So we started off in the 1960s in anti-poverty context with appreciation of the value that CHWs bring, especially in the early community health center movement, but in other applications in health and public health. That led to a lot of grant funding, pilot programs, That in turn spawned increased rigorous research, which has demonstrated CHW value across a wide range of disease conditions, public health issues, and populations. And that in turn is driving this increased attention and investment. So we want to share with you a kind of conceptual framework that starts with the importance of understanding who CHWs are and what they do, recognizing that we talk about integration across a couple of contexts, public health and healthcare, and we'll talk about that a little bit more in a moment. We're going to offer 3 forms of CHW engagement for your interest and to focus the discussion on what we mean by integration. And we're also going to present 4 domains in which we think integration is happening. The focus of this webinar is integration of CHWs into care teams within provider organizations. But in fact, integration is happening in other respects as well. We dedicated our June 16th webinar to understanding the CHW workforce, defining it, looking at what CHWs do, where they work. We recognize that this is an umbrella term for literally dozens of job titles. We've presented a common definition of the workforce drawing on the American Public Health Association. We have presented a national standard for defining roles and skills for CHWs that provide the basis for a common understanding of their core competencies based on the CHW Core Consensus Project, or C3. And we want to emphasize that CHWs are people. CHWs are a workforce. CHWs are not a model. And we hear a lot of talk about the CHW model. We think that is not particularly helpful language. We also hear about people using CHWs and models using CHWs. Again, that is a topic of some sensitivity for CHWs, and I think Lucia may comment on that more. But we just want to emphasize that these are people as other members of teams, and they should be accorded the proper respect. There's a growing emphasis on an accountability for addressing upstream issues, non-medical issues that drive injury and disease. And as we see a shift towards value-based payment systems, global budgets, bundled payments, healthcare provider systems are taking increased risk for the health of their patient populations. This increased risk is driving, in turn, a lot of attention at how providers address issues of prevention. Most of the focus now is on secondary prevention, but increasingly there's discussion of actual primary prevention and what health systems can do to address so-called social determinants of health. CHWs, as we've talked about before, really bridge the public health and healthcare worlds. They bridge healthcare providers and community-based settings, and so they are really sitting at the nexus of healthcare and public health. Technically, healthcare is part of public health, but in fact, healthcare drives over 95% of all health expenditures. So unlike many countries that spend more on education, employment, and other social services that help prevent disease, that's not how this health system and our social system expenditures are organized, and that brings increased pressure and challenges for both the healthcare and public health systems. So CHWs are sitting at the center of a lot of discussion about what to do about this, and that's driving a lot of interest in integration. We want to offer 3 forms of integration that we see happening. Only two of them we would say aren't really integration. CHWs are used to support clinical operations that don't even use integrated interdisciplinary teams. CHWs are also used, as this somewhat pejorative language goes, as adjuncts to teams not members. What we want to discuss as integration is where CHWs are actually members of interprofessional care teams, where they are valued, where they are integrated, where their expertise is recognized as equally important, and where they share roles in decision-making, in policy and program formation, and et cetera. We're going to get into more detail about that. I'd like to invite Carl to just talk a little bit more about these first two forms of so-called integration that really don't look like integration to us.
Sure. There has been a lot of talk about patient-centered care teams, and in fact, the American Medical Association has accepted a report recommending community health workers as part of teams, but they are, to no one's surprise, describing these as physician-led care teams. The nursing community has taken a bit different approach, but again, encouraging community health workers as part of teams. We have to face the reality that a lot of healthcare organizations simply are not there yet in terms of providing team-based care, and yet there are these organizations. In fact, have, and I'll present an example of one of these later on in the webinar. They don't actually have team-based care, but they're community health workers providing important supporting roles in coaching, supporting chronic disease self-management, and that sort of thing, that where community health workers are clearly part of the clinical operations, but they're not in a team model. But the fact that a team exists does not mean that the community health worker is really accepted as part of the team. They may be considered extenders to some folks who are members of the team, prominently of course the primary care physician or nursing staff, and they are somewhat beholden to those other members as the delegators of tasks. But they one of the distinctions is, and we'll come back to this later, that in those sort of partial integration models, particularly the second one, community health workers tend not to have a lot of input to the team. And as some of what Jeff has just been saying suggests, the community health workers in a really unique position to contribute to the team's discussions of the needs of a particular patient. They have the opportunity to contribute invaluable information about the context of the circumstances of the lives of their patients. So these are steps, perhaps we might say, in the right direction, but they don't take full advantage of what CHWs can do.
Thanks a lot, Carl. We also think it may be useful in terms of a conceptual framework to talk about 4 domains where integration happens. And, integration is a term that is used imprecisely and loosely to cover an awful lot of stuff. So we talk about integration of CHWs into integrated care teams. Those care teams are operating within the context of healthcare provider organizations, hospitals, community health centers, physician networks, et cetera. And those, in turn, are operating in a larger context of public health and medical treatment and prevention programs. All of this interlinks with financing of services. So we have 4 separable and interrelated domains, and we hear about integration in all of them. So integration of CHWs into financing, as in how do we pay for CHWs in insurance systems, notably a lot of discussion about Medicaid, but private payers as well. We've got some temporary demonstration programs, DSRIP, some of the SIM, the State Innovation Model grants. Those are supposed to drive payment system innovation over the long term. We have yet to see most of that, most of this effective work actually integrated into financing. But CHWs are figuring prominently in these discussions. We have categorical health programs managed by state, county, local health departments for a wide range of diseases and conditions, notably chronic disease. So we have diabetes programs involving CHWs and integration of CHWs into asthma, cardiovascular disease, HIV, AIDS, etc. So we hear integration in that context. We hear about integration of CHWs into medical model challenges, notably the care of high-risk, high-cost patients with multiple comorbidities, chronic disease and homelessness, and perhaps behavioral health issues, substance abuse, etc. Healthcare organizations are innovating because those folks are driving the costs that health systems are seeing. So we see CHWs being discussed in terms of treatment and prevention programs at the meta level for ER diversion, hospital readmissions, avoidance, etc. And then, of course, how do we integrate CHWs into particular hospital and healthcare systems, into particular provider organizations, as well as the care teams? So integration of CHWs is happening across a wide range of domains. And I think it's important to understand when we're looking at this beast. We used the metaphor of the elephant in our first webinar. Depending on where you touch this, CHW looks different. So our perspective in public health departments may be different than in provider systems, and we should be aware of the overall context. CHWs are also discussed as being integral to addressing a wide range and fragmented set of healthcare and public health domains and challenges. So we hear about CHW integration in the context of integrating chronic disease treatment and prevention, integrating clinic and community-based care, integrating behavioral health and primary care, integrating oral health with medicine, addressing challenges of care coordination, addressing how to address the social determinants of health. Again, CHWs are figuring in all of these discussions. And I think it's also important to note that as health systems and organizations look at integration of CHWs into care teams and organizations, that typically comes along with organizations innovating beyond direct client interaction and family interaction roles into the development of community-based partnerships and collaborations and the development of supplementary programs and services, non-medical services that healthcare organizations are providing to address some of these prevention challenges. Lucia, do you want to say anything more briefly about this as an important theme in work you're doing?
Sure. Thank you, everyone. Hello. So I think that one of the pieces that can you hear me? Okay.
Yeah. Yep.
Okay. Thank you. One of the pieces that community health workers try to do is to become more involved with community resources, but to not only the extent of making referrals, but really developing relationships so that it can make it easier for that patient or that client to really utilize those services. So hands-on type of work around maybe going to those providers, those appointments with those individuals, housing, going to the shelter, meeting people there. So those connections are very important with those community-based organizations. Working for a hospital setting, I think sometimes there's a little bit of disconnect with that, and it is very important to still be connected and establishing those relationships.
Thank you very much. This underscores another theme that we have talked about with each of the 5 states in the learning community, as well as in our previous webinars, and that is that it's important to use or recognize all of the core competencies of CHWs, including advocacy for individuals and communities and this community-based relationship work. If CHWs are kept within the walls exclusively of provider institutions, those organizations are not getting the full benefit of what CHWs can do and the value that they bring to health systems. So let's open it up at this point and invite some questions and discussion. Again, these webinars are intended as an opportunity for you to learn from one another, not for us to just talk at you. So we would love it if you could share examples from your states. How are you dealing with these issues? How does this, some of the issues that we've just been talking about in terms of the conceptual framework play out in your own experience? And operator, if we could open the lines for people to ask questions, that would be great.
Thank you, sir. If you would like to ask a question, please signal by pressing the star key followed by the digit 1 on your telephone keypad. If you're using a speakerphone, please make sure that your mute button is disengaged so that your signal can reach our equipment. A voice prompt on your phone line will indicate when your line is open to ask a question, and we do ask that you please state your name prior to posing your question. Again, press star 1 to ask a question, and we will pause for just a moment to allow everyone the opportunity to signal for a question. And again, that is star 1 to ask a question.
What are some examples from your states of how you are dealing with these issues? Anybody? We've met you, a lot of you, so we know you've got things going on.
And again, if you would like to ask a question or make a comment, please firmly press the star key followed by the digit 1. And we have no questions. Oh, I do apologize. We just had a question pop into the queue, and we will go to that question.
Hi, I'm calling from Texas, and I'm really proud of how Texas is working with elevating the CHW status across the state and all the different entities. Back in 2010, I still remember CHWs telling me, you know, we love our work, but all these grants and everything are writing in lots of money, but we're not getting any of that money. And since 2010, I see that more funding is addressing the needs of the CHW, having them more integrated into that plan, looking at stipends, compensation, lots of, you know, it definitely is being elevated in the last 7 years.
Thank you. I think that's an important observation. Carl, as our colleague from Texas, do you want to comment on that?
Well, I can comment more generally on it. I do know there are a number of provider organizations that are doing great work in terms of increasing the integration of community health workers, like Baylor Scott and White, and some of the Medicaid health plans. But I think the point the caller is raising is important, echoing what you said, Jeff, about the past pattern of grant funding. We have to recognize, in fairness, that the incentives that are set up by grant funding don't really encourage the employing organization to do much for their community health workers. Some have done more than others, clearly. Some have had a more enlightened or long-term view of this. But with grant funding, much of this is driven by research objectives, so a lot of resources go into actually conducting the research. But with a short-term funding prospect, there is not much incentive for the employer organization to invest in training or career development, or even to pay what might be considered a living wage, because the individuals employed don't expect to be there for very long, so they don't have much bargaining power. in that sense. But we are seeing a shift, and we also have examples in Texas with safety net providers who are investing in community health workers out of their general operating revenue, you might say, rather than a specific source of funding dedicated to community health workers, because we still in Texas have high numbers of uninsured folks, and these safety net providers are seeing continuing high cost of uncompensated care, and community health workers have proven to certainly some of the providers in Texas that they can help to reduce some of those avoidable costs of uncompensated care.
Thanks, Carl. Operator, do we have any other questions waiting?
And we have no further questions on our roster at this time.
All right, thank you. I see a question from Chris Needham in the chat box here, so I'm going to read it, and then I have a brief comment, and I'm going to invite Terry to comment on this question. Has there been an example of setting up a social provider network, much like a medical provider network? This would allow those social organizations to prescribe and document within the electronic medical record. So one example approaching this is in Massachusetts, the legislature created something called a Prevention Wellness Trust Fund through an assessment on some large provider systems. And there was a $60 million fund to be spent over 4 years on community-based prevention efforts and connections with the healthcare system. This included, this is administered by the State Department of Public Health, and it included contracting with community health workers in each of 9 grantee networks. And there's some work along the lines, although it wasn't called a social provider network, both in terms of linking groups of community-based providers with clinical settings, and also efforts to get access to electronic medical records, or at least an improved data highway. Terry, do you want to take us a little deeper into that?
Well, I was actually going to mention something else, although I will just say, can you hear me? Am I on mute?
Yeah.
You can hear me. Okay. Yeah. So that prevention and wellness trusts, care systems that were funded around the state and often based in municipalities, by the way, and linked up a whole range of kinds of providers to health care providers, did institute a system of two-way communication between referral organizations, in communities like the YMCA, where folks might be referred to get some help with, nutrition, diet, exercise, and, chronic disease self-management. So they have a system in place that some of the grantees had more success at getting community health workers interventions included in the medical record than others. It's still a challenging thing to pull off, but I think everyone who was involved knew that was a crucial thing to do. So there's been some progress there. And then another area in Massachusetts, which is just emerging, but which is kind of more directly addresses, I think, what you're saying in the question, and is very cutting edge, which is the accountable care organizations, the new form of service delivery that's to put a whole range of types of organizations, including health organizations, to be financially and quality-wise responsible for the outcomes for their patients, not just paying them on a fee-for-service basis for how much they provide, but rather how well they provide it. They are actually, our state Medicaid is actually included and will fund directly some what they call community partner organizations. And social service providers can be linked through contracts with some of these providers. And I think in that instance, there's going to be a real strong effort to make sure that there's electronic medical record, tracking what community health workers bring to those systems of services as well. But I'm not aware of any brilliant accomplishment in that regard, and that's an important question.
This is Carl. I'd like to add briefly to that as well. The first, that many of you may be aware that the Accountable Communities for Health initiative out of CMMI is targeting essentially that kind of thing, where there are systematic relationships, there are structures set up between healthcare providers and social or human service organizations in the community. And there's some interesting experiments on that. There's one that's starting up in Hawaii, which is a partnership between United Healthcare and a federally qualified health center that is going to take a very advanced approach to this. Part of Chris's question is about the ability of these social service organizations to document within the electronic health record, and I'm not aware of any systems yet that are at that stage. But the Accountable Communities for Health is one move in that direction. I'm also aware of, we will do this more than once, and Lucia may want to comment on this as well, is that dealing with social determinants of health is a lot more than just making referrals to social service agencies. And if someone is approaching you about a way of doing that and saying that's your answer for social determinants, you should look at it with a high degree of skepticism. There's a lot more involved in that. But there are several organizations that are starting to provide support systems for that kind of referral. And one of them is called Healthify. Some of you may have heard of it. What's interesting about their approach, and this is mainly just a data resource for referrals, really, and there is more to it in terms of tracking follow-up and things like that, but it's primarily that. What they've added to the mix is some data analytics, and the providers and the social service organizations in their network can look at those analytics and say, a high proportion of our referrals are going to this one agency. We should be developing, this is we, the healthcare provider or health system, we should be developing a relationship with that particular social service agency or housing authority, whatever it is, a closer working relationship based on the analytics of the needs of our patients. And that is a very encouraging development, certainly.
Lucia, are you doing anything in Rochester Health along the lines of what Chris was asking about, particularly with respect to electronic health records and community-based providers?
One of the things that we have is RIO, which was really exciting for many organizations. Prior to me working at Rochester Regional Health, I worked for a non-for-profit, smaller clinic, and we relied heavily on RIO because we could find out if our patients had been hospitalized. And since we had an outreach program and also a health homes program, we were able to track our patients without having to call. So it was easy access to that information. And I believe many organizations can participate in RIO once the patient gives them the consent. So that was one of the initial kind of system information set up for us in the region. Now, it hasn't worked 100%, but it definitely has given us more information. If you're a smaller organization, CBO or program, it is harder to get the information directly from the hospitals. Or even if you call in a clinic, if you're doing some follow-up. But I believe RIO has been helpful in getting us connected with that information that we need.
Lucia, this is Terry. How do you spell that? Is it R-E-A-L?
It is R-H-I-O.
Oh, I see. Okay.
Thank you very much, Lucia. We have June Hunter trying to get in on this conversation, but June, it looks like you're not on the phone. So if you want to type, you can join by phone, and we'll get you in when you join. That may be easiest. But if you want to type your feedback, then we can make sure we're addressing it. In the meantime, I just want to go back to something Carl said, and then we're going to go on to talk about principles with Terry. But This idea that addressing social determinants of health it relies principally on referrals is indeed faulty, particularly in areas where there are inadequate services or the distribution availability of referral services doesn't meet people's needs. So in Boston, for instance, this mecca of social services delivery, there is such a severe shortage of affordable housing, which of course is linked tremendously to health outcomes, variety of health outcomes. But there's so much of a problem with affordable housing that a prominent referral network involved in healthcare delivery has stopped screening patients on housing needs, except for to just provide them very basic information they can follow up on themselves. But they're not getting person-to-person help on this because there's just not enough resources in housing to send them to. And similarly, people who need legal services, even in Massachusetts, there's a tremendous gap between demand and eligibility for legal services and the availability of them. So sometimes it means creating new services, advocating for services, because the idea that you could refer people to services that are in too short supply or don't exist is just a bridge to nowhere. CHWs are critical to referral services and these partnerships, but they also may be critical towards identifying needs that have to be addressed through advocacy and more creative partnerships among community-based organizations.
That's a really great point, Jeff. This is Terry, and if I can just add real quickly, you reminded me of a conversation I had recently with a program talking about precisely what you're talking about, where the housing options were just not there. But one of the crucial roles of community health workers in a less activist way than what you're talking about is also to help people sort through what their options are and to support them in the process of trying to figure out how to cope as best they can. So just having referrals happen electronically is, even in the Prevention and Wellness Trust sites that we talked about in Massachusetts a moment ago, was never a full substitute for having community health workers and actual people that were helping people grapple with these issues. So one way or the other.
Thank you, Terry. We have a question from Tish. Are we familiar with health leads?
Yes.
And there's Department of Health and Human Services contracting with them.
Yeah.
Yes, indeed. And the organization that I was just referring to is Health Leads in Boston, and they've got pamphlets that they're handing out now to patients to allow patients to try to find their own housing, but they have stopped dedicating the availability of Health Leads staff to work with people on housing because there's just too little housing out there. Health Leads is a fantastic resource. It should be clearly distinguished from community health workers, however. Typically, Health Leads advocates within healthcare settings are undergraduates who are trained to screen and then provide follow-up and referrals. They're not typically community health workers, and by definition, that's not what Health Leads is trying to do. It's a completely different approach. CHWs, by definition, are people who come from the communities they serve or have unusually close understandings of the communities they serve. They share culture and life experience with the people that they serve, and so they are able to establish relationships of trust. They are able to get past power differentials, and in all other ways that we've discussed, they really are able to provide a different quality of interaction and support. So that this is, I actually work closely with some key Health Leads managers in my work through Boston University and have high regard, but that's not to be confused with community health workers.
And
okay, we'll move on in the presentation. We've got
pardon the interruption. We do have a question in the queue if you would like to take that.
Yes, let's finish up with that one, and then we'll move on to talk about some principles.
And we will go to that question. Caller, your line is open. Please check your mute button.
Thank you. Sorry, I didn't know that was for me. Hi, folks. This is June Hunter in Nevada. I am with the American Cancer Society and also work closely with our Community Health Worker Association here and through our state health department. But what I just wanted to briefly mention, we were talking about funding community health workers' work, and we have found through our community empowerment and equity funding, we specifically fund FQHCs to improve their cancer screening programs. And vital to the program and one of the deliverables in the grants are to have community health workers on site working within the clinical system to help us improve that cancer screening. So the callbacks, the referrals, and so forth and so on. And the idea of the grant, of course, like many others, is not long-term, but it is to establish and build their capacity in terms of the cancer screening with the staffing of a community health worker to help the other team members get that person in and screened. And we have found, while the grant funding period ends, the key to our work is to make it sustainable to the organization. Here in Nevada, we have been very fortunate working with some of our FQHCs to see the work we have saw funded now continue and to be absorbed in their organization. Now, how they're funding it moving forward is the challenge, of course. But in terms of cancer screening, the community health worker is invaluable, and we have tons of data through these grants to show that. So I just wanted to share that with our call today. And it's just not to Nevada, it is nationwide.
Absolutely. Thank you very much, June. It's a really important point, and you're right, there's a fair amount in the literature to support the experience that you have described in Nevada. So that's great. Thank you. Terry, do you want to take us forward talking about principles for integration?
Sure.
We're kind of moving into a new chapter of the presentation here as we're going to get into more detail about how integration can actually work in organizations and teams.
Sure. And I want to just comment on June Hunter's point also, just to say that that's a good example, by the way, of how community health workers do get taken up into systems and integrated into systems is oftentimes based on an initial pilot study where the evidence shows that, it's really worth it to the provider or the organizations to bring them on into their budget. How that's sustained in the future really depends on the payment systems and the delivery systems changes that are underway. But that's a great example of how that works often. So yes, moving into what we're talking about is principles for integration, and really what we do is start out kind of broad, and I hope someone else is moving the slides. Are you doing that, Jeff? Yes. So we'd start out with kind of some broad background principles for thinking about integrating community health workers, and we want to make sure that integration is, as Jeff said, a term that's used a lot, and it can become vaguely meaningless unless we're clear. So we're going to try to get a little bit clearer gradually here to talk about what that really means with bringing community health workers in. Of course, some general background principles about this is that, clearly the evidence shows there is a lot of evidence now, and just as some of our question askers here, June in particular, mentioned just now, there's a lot of evidence for how community health workers have been able to help health systems achieve the famous triple aim, which means a little bit of something different depending on who's saying it, but basically of health reform, which is just improved quality of care, improved patient experience, those two, improved health outcomes and improved cost picture, a better cost-benefit picture for health services. But health equity should be a very essential part of that picture of improving health systems and health care. And it's really what we sometimes call the quadruple aim. It's intricately interconnected with all of those other factors. And when health equity in particular becomes really the center of what one is looking at, community health workers and bringing them into systems becomes really important and essential. So that's something that evidence and history shows. Another general principle to think about in approaching community health workers being integrated into whatever systems you're talking about is to absolutely understand, and we've said this and we'll be saying it throughout this whole presentation, is the understanding and respecting what community health workers really bring to the work, because without doing that, integration can't really happen well, and you're not going to get the outcomes that you need or that you want and that you're aiming for and that you could get. Another principle of community health workers and bringing them into systems, they are patient-centered. They have been patient-centered long before this was sort of a buzzword and a byword for transforming healthcare. They are, by definition, patient-centered. They focus on the people and the communities that they serve, that they come from, and so they also take a holistic approach. And so you don't want to try to squeeze them into some little niche, just like Jeff talked about. We're no longer able to take advantage of community health workers being in some little marginal section of services in some program where nobody knows what they're doing or vice versa. That just isn't going to cut it anymore for a variety of reasons. And so everybody in organizations has to be made aware of what community health workers bring, who they are, and it's not just something that you put onto a single supervisor or even a program. The other important aspect of community health worker integration as a background principle, a general principle, is that because they are people and patient-oriented, and because they are holistic in their orientation by definition, they look at people not just in a medical or health way specifically, but in their whole environment and understanding, what context and what concerns are shaping what they're able to do for their health and what the challenges are. It is not going to really benefit you as much as it could, and it's certainly not going to be as compelling for the community health worker themselves as a staff person if you just focus on one or two of their skills or core competencies. So just having them do outreach, for example, in the past, which was very common the case, go out in the community and find people and bring them in or something, was just simply not taking advantage of what community health workers can really offer. And so the impacts and the changes in services were not, in fact, evidence showed when someone reviewed some of the literature that it was more effective in terms of affecting outcomes or process measures that community health workers be doing education and support and, screening and, helping people get to services and so on at the same time that they're also providing outreach, not just outreach. Next slide. So talking about integration, again getting a little more concrete here, is that what really is integration except for bringing people together, bringing whatever together, communicating. It's built from communication, from contact, and of course respect. So knowing that community health workers have a very distinctive perspective that we've been talking about throughout this presentation already, that no one else is really going to bring to the team, then you don't want to start planning your programs or your integration of community health workers into whatever existing programs or health systems you have without including them, because they're going to bring some eye and some understanding of patients or their own way of working with patients that others in the team aren't going to see. And so just plugging a community health worker into an already designed program is once again setting you up for not as effective an effort, not as effective an intervention, not as effective a team, and not as happy community health worker. And aside from the importance of seeing that community health workers get to realize their own professional skills and accomplishments, it's also clear that, besides not paying people well enough and not working with them respectfully in the ways that make sense for them, can also contribute, just like with any other staff, to higher turnover rates. So it's important to really recognize that involving community health workers has multiple advantages, right from the beginning. And then, of course, getting down more concretely into how you integrate community health workers into team settings. You obviously you want to have regular meetings with the full team. You don't want to just have community health workers talk to their supervisor and then have the supervisor communicate to the rest of the team in some kind of intermediate way. Community health workers need to be a part of the team and meeting with them regularly and sharing information about patients and case conferences and all of that. And, of course, they need to meet also more frequently than that, even with their direct supervisor. This is all about communication. That's what integration is based on. And then, again, along the same lines, communication in the electronic medical record, electronic health record. Someone asked a question about that a moment ago. This is increasingly recognized as a best practice. Again, if you want to integrate community health workers and have the team understand what they're doing, what they know about patients that can be helpful to others, and what they've experienced and what they've provided for patients, they have to be able to read about it in the electronic health record or medical record. And community health workers should be able to read sufficient material in the electronic health record to know enough about the patients from other providers' perspective. So that's challenging, but it is a best practice at this point, and that's a crucial piece of communication. Next slide. So now we've talked about both teams and organizations, and we're going to hear more about organizations. Lucia will talk about that in a moment in a very interesting way. So I'll be a little more abstract here. But we all know that, that there are a whole range of different kind of challenges to integrate community health workers into large health systems, just like Lucia talked about a moment ago. Community health workers can be included in Jeff, in many, many departments and divisions within organizations. And likewise, actually in smaller health centers or smaller organizations, but the scale is different. And so naturally you'll have more complex systems that will require more complex thinking about systems. But I should also point out, and we should also point out, that integrating community health workers poorly or well is not dependent on the size of the organization. We know of hospitals that have done a beautiful job of integrating community health workers and getting them into communities more often, and some smaller organizations and health centers that aren't doing it very well. So the principles are similar, just the scale and complexity differs. But the bottom line is that you have to think in terms of systems. You have to not just try to plug community health workers into one little spot. It's systems thinking. So that includes organizational policies and procedures. Community health workers need to have job descriptions that are accurate with the human resources folks. You need to have policies and procedures that acknowledge the distinctiveness of what they do. Maybe they're out of the office more than many others. Maybe they don't work the exact same hours that others do. All of this has to be built into policies and procedures. You can't be bumping up against that barrier. So that's another feature or aspect of integration. And when you're thinking about people worrying, often nurses do, for example, about community health workers' scope of practice and are they going to work outside of what they're supposed to do and so on, clarifying what community health workers are able to do and want to do and are trained to do or prepared to do and what they're not is important, but so is it doing the same thing with their colleagues so that everybody works in a complementary way and is not trying to duplicate. Again, that's a form of integration. And then, of course, as some of you have already brought up, funding. Integration, real integration where, as Jeff says, you don't just keep coming off of one grant and going away or coming onto another one and changing what you do. really requires sustainable funding. We've had a discussion about that in another webinar, but that's a really important part of integration, which is how they get integrated community health workers into payment systems and sustainable flows of resources. And then finally, moving quickly into the process, again, we're just getting a little more concrete, the same kinds of ideas that I've been talking about and others have mentioned, and Lucia will really get into detail about. Same thing. You've got to do systems planning in advance. You've got to really do effective recruitment and selection of community health workers. That's essential, and there's plenty said about that. We can talk about if anyone's interested. The training and quality of the supervision and the training of the community health workers, all that has to be built into how they're integrated. An important point that Lucia mentioned, and she'll probably elaborate on, and we've all seen, you're going to try to make changes and get community health workers brought into, in a systematic way, any kind of organization. It's really crucial to have leadership promoting the relationship building and the collaboration between different kinds of professionals, including community health workers. Champions are really essential to making these integrations work of all kinds, not just community health workers, but also community health workers being brought into systems. And the other obvious workforce issues to be able to really sustain community health workers in a system in the way that you do other staff is you've got to plan how to help them community health workers get the training and the time off to go to meetings and professional development and come up with ideas for how they can move forward in their career. And that does not necessarily mean leaving community health work at all, although it can mean that. It's not necessary to think that way, because as community health workers become more skilled and more experienced, they should have, a sense that they're respected and they have opportunities to move up to supervisory positions where they make great supervisors of community health workers. Training, we've heard that we can hear that from Lucia as well. She's definitely accomplished all of those promotional steps in her career. Once again, sustainable funding is going to require research in order to, and just as the example of the case from Nevada that we heard about a moment ago, you got to track outcomes. You've got to track what's going on in order to be able to develop the case for your organization or with policymakers to fund community health workers sustainably. And then finally, the next slide, the last one, is where we really, really get down to the very concrete level of what I've been talking about. I think all of these are sort of self-evident after what I've discussed. You've got to do a whole readiness for change assessment in organizations. Experienced people in this area really have, readiness for incorporating community health workers. Scales and assessments that they have used. You can use redesigning the patient flow, redesigning how relationships work with community health workers as a part of the team, and working with all the team members. And, of course, the logistical support and the infrastructure can include the electronic medical records. It also, of course, includes when you're doing population health, this whole matter of being able to develop panels and track who the folks are that you want to be served by, let's say, the complex care team. So you have to have that kind of infrastructure. And in some cases, in the health reform context, the delivery system reform investment funding can be used to do that sort of thing, the so-called DSRIP funding. Some of the federal funding for health reform has been able to provide those kinds of infrastructure changes that are needed to do population health and complex care team work. And then finally, when you're bringing community health workers into a team or a system, there are orientations that we are aware of that have been developed that are very systematic based on evidence and experience of how to really bring community health workers into the organization from their perspective as well. So those are all the concrete aspects of integration as an action, as a series of actions.
Thank you very much, Terry. It's important to consider what does real integration require from the perspective of CHWs themselves who are actually in these work settings and teams? Lucia, do you want to comment on this, please?
Sure. So one of the things that I wanted to mention is that sometimes it is hard for us to have an honest conversation around, real versus full integration. And a lot of the conversations that we have had for the past hour and a lot of the examples that were shared by Terry, it's almost like that's my life every day. And some of the stuff that I'm moving forward with and that our organization is moving forward with, but certainly has been at times a struggle. And at the same time now we're seeing that we're moving forward more and more towards a real integration. So for me, when I think of a full integration, it means that, okay, we have checkmark our boxes, right? So we know that, okay, we have invited them to the meeting, we have made sure we secure space, and we know who they are. But to me, a real integration is looking at really what it comes down to is respect for the workforce and the scope of practice that CHWs have, and really supporting and valuing their voices when it comes to complex cases that are being discussed, for example, and bringing them to the table and hearing out based on their relationship with that patient. They might have different information that has not been shared with their providers, their nurses, the social workers even. So I think that to talk about real integration, we do have to have an honest conversation about some of those small things. Respect for CHW's life experiences, I think, is key for real integration of community health workers, because those are things that can connect those CHWs with those patients in a different way than anybody else can connect with that patient. And we have to have real value to those life experiences, right? So that our voices are valued equally within that team. I'll give you an example. I have gone to team meetings where I was invited to those team meetings, but it was almost taken over. And we had important information that could have helped, or contributed to that team meeting. However, we had to kind of do it on the side afterwards because it was just kind of taken over. And I have been also in team models where, we were invited and asked, what do you think? What do you think about these options that we're having? And also the other piece is that we also bring that advocacy on behalf of the patient. And at times, sometimes that can be hard, but it is extremely important. The other piece is looking at CHW's leadership. And when I think about leadership, there's different ways in which we can talk about leadership, right? You don't have to be in a supervisory role to have to kind of lead or participate. So we want to engage, empower, and educate our patients. And that's probably at the core of what we're doing, or coaching, I would say. But that CHW has to feel empowered to be able to kind of express their opinion around the care of that patient. CHWs have to be part of the determining, what is going to happen, or at least, valued that information and influence on internal systems. I'm thinking of an example right now. We had a patient that was a high ED utilizer, or currently is a high ED utilizer, and the community health worker actually, with my support, we schedule a meeting with the director of the emergency department, which is at times very hard to do because he's very busy. And we invited community organizations that were working with this particular patient. And so a lot of resources had been drawn into working with this patient. And I felt like the community health worker had the strongest relationship with that patient, was able to advocate, and was able to actually lead that meeting. And it was extremely powerful to see that. Any other comments? Well, I'll move on to CHW Voices. So recently we had a conversation during at Unity Conference, which was a conference for community health workers, and we talked about full integration in looking at real integration, and we discussed, well, how do we become more integrated? Like, what is it going to take? And this is also at a higher level versus just the integration into care teams or complex case reviews and things like that, but into the healthcare system. And the conversation was around what are the strengths and opportunities that we have as community health workers, and also what are some of the weaknesses or threats that could impact that full integration or real integration. So we talked about support from leadership and colleagues. Where I work, I have been fully supported and have actually identified those champions. They have introduced me to other groups within our system, because we're quite a large system, that has opened up the doors for us to integrate our program into different ways. That has been extremely important. But support also means that you are allowing for the CHW group to also have a voice and a leadership voice around some of these integration models or integration ways that we're doing. So mobilization of internal resources and champions is really important, and really they are key in integrating the CHWs. Empowering job titles and clear job descriptions, that came actually as a weaknesses and threats, because we have different titles, and so that what it does is, instead of having a clear interpretation of the scope of practice and who we are as community health workers, if a smaller organization uses the term navigator versus outreach worker versus a community health worker, it sometimes creates confusion because of the different titles and the job descriptions. Certainly we know and we understand who a CHW is, but that can create a lot of confusion for people and organizations included. We talked about acknowledgement of community health workers' impact and expertise. So again, looking at those lives experiences and not just looking at a degree, because educational background is important. However, those life experiences that those community health workers bring, or that we bring, is not something that you can obtain through a college degree. So we want to make sure that those are respected and acknowledged with dignity. And training and continuing education also, it's one of those things that it can strengthen the profession, but it can also create a weakness. A lot of the times we hear, I also, because I wear two hats as the chair of the Community Health Workers Association of Rochester, we had a meeting today talking about a program, an HBOG program, and they're kind of struggling with the fact that there was this wonderful training that was provided to a group of community health workers who come from those communities and are ready to go. However, they're not able to find jobs because that training is not recognized. And so I think that also creates a lack of understanding around community health workers and an opportunity for them to be integrated. And we talk about respectful, informed supervision. I think that sometimes when we implement the programs, we also have to provide support to the supervisors, and we also have to think about who the supervisors are that come into these programs. It's not to say that anyone could be a supervisor of the community health workers program, but I think they do have to have that real understanding of what it means to work with a group of community members and, what are some of their own needs as staff members. So on that note, I'm going to pass that to Jeff.
Thank you very much, Lucia. And we'll come back to you in a few minutes to hear more specifically about the work you're leading at Rochester Regional Health and really get into the implementation on the ground there. We want to open it up for another couple of minutes to see if what questions are you hearing or what challenges do you face in promoting CHW integration in your own states or organizations. So, operator, if you could remind people how to get their questions asked, that'd be great.
And as a reminder, that is *1 to ask a question. And again, that is *1 to ask a question. And if you are on a speakerphone, please make sure that your mute button is disengaged so that your signal can reach our equipment. Once again, that is *1 to ask a question.
Anybody?
And we have no questions on our roster at this time.
Okay, I think we'll move on then. Carl is going to talk with us about the challenges that may arise in the process of integration, especially with respect to culture within organizations. Carl?
Yeah, thanks, Jeff. And this is really building on, I think, a point that Lucia made at the end of her presentation about supervision. I think it's important for folks to recognize that supervising community health workers is not like supervising other kinds of personnel. And I think you all can appreciate that. What I'm going to refer to here is just one aspect of that, which really affects the broader integration process, certainly, as well. But it's a challenge for supervisors as they attempt to support community health workers in their work within a healthcare organization. And I don't think anybody's under any illusions about this, but there is a culture of healthcare, and there is an organizational culture as well, but an individual organizational culture. But there's a culture of healthcare that is not the best starting point, if you will, for adding personnel as different as community health workers are. And so anticipating this, being clear-eyed about this is really important. I should say that these slides we're about to review are actually from a pre-existing presentation as part of a workshop on supervision. But we thought they were apropos of this setting as well. So the first of these, and we've supplemented these with some actual quotes from real community health workers, that in healthcare organizations in general, and this is a generalization, but there is clearly a hierarchy based on the extent of the individual's clinical knowledge, with physicians at the top. And I don't think we should be shy about acknowledging that. The problem is that the community health workers' expertise and value are not related to their clinical knowledge. They have very little clinical preparation, and they may have less formal education in total than other personnel within the organization. But the point is that if there's a totem pole of authority and power based on extent of clinical knowledge, the community health workers are most appropriately not placed at the bottom of that totem pole, but separate from it, because their source of expertise is just different. And so it's important to recognize that. And I think that we see is from some of these quotes that eventually folks in healthcare organizations do come to recognize the value that comes from the particular type of knowledge, the domain of expertise, we sometimes call it, that community health workers have. it is true, and we need to acknowledge this and provide in the supervision structure that community health workers need clinical backup. They need to feel safe to say, I shouldn't be answering that question, or I don't know the answer to that question. If it's a clinical question, they need someone they can get a hold of, call for backup, so to speak. And it may not be their direct supervisor on a day-to-day basis. They may have a separate clinical backup resource that is available to them. But it is important to recognize that there is an issue of power, and it may lead to, and does happen in some organizations, that people throw around their power and authority kind of willy-nilly and may be unconsciously creating barriers or actual harm in their relationship with community health workers by throwing that authority around. The next area has to do with healthcare organizations, and particularly in larger organizations, that roles are fairly narrowly defined. And we can think of some extremely narrowly defined roles like a phlebotomist, and their job is very, very much circumscribed. And systems try to build, this is back to the old Industrial Revolution and the mass production theories of Henry Ford and so forth, that big systems tend to specialize roles and they narrowly define them. But a lot of systems kind of trip over the fact that community health workers are neither clinical nor administrative personnel. They're neither one. And sometimes you will have challenges with human resources in a large organization figuring out how the heck are we going to classify these folks. But also the fact that community health workers are often working independently and working in a different style. We've heard anecdotes about, for example, a community health workers on the phone in the clinic talking to a patient, and someone overhears them and complains that it sounded like a personal call. And when you think about it, a lot of what community health workers do is about developing and maintaining relationships. So their contact with patients may sound like a personal relationship. So there are a lot of challenges about role definition within an organization that have to be confronted. In a related point, that services are built on specific interventions. There is a diagnosis, there is a plan of care, and there is a series of treatment steps that are followed as part of that plan. And the community health worker style of operation is not quite that way, that they may be identifying a very broadly based need in the individual or family that must be addressed in order to relieve some of the pressure on their health status directly, or that may relieve some of the pressures that limit the patient's ability to access the care that's available to them. And so the community health worker needs a lot of flexibility in that. They can't necessarily follow a very tightly defined protocol. And so I remember one, it was a research study actually here in Texas, in which it was related to diabetes, and the community health workers in the study were supposed to be making 2 visits, home visits per month to the patients who were enrolled in the study. And the investigators found out very late, too late to really change things, that some of the community health workers had been, if they felt that the family had a greater need, that they were making additional visits and simply not reporting them, because that's what they understood the family to need. And so it meant that for that study, they had to throw their data out because the protocol the data were contaminated because of violations of the protocol. So it can be challenging for organizations that are used to focused diagnosis and treatment plans that are very, very specific in nature, for the community health workers to have that kind of flexibility. And then I mentioned organizational culture, and each organization is different, but community health workers may have to, as the first quote indicated on this slide, the style that works in the office or in the clinic in terms of personal presentation and language and appearance and so forth may not be appropriate out in the community. And it is often as part of even a personal safety consideration for community health workers not to dress too formally when they're out in the community. So it's important that community health workers are working with a culture within the organization, and they are also working with multiple potential cultures, not just ethnicity-based, but multiple cultures within the community. And they have their own cultural background. It is also true that a lot of healthcare systems are, in their makeup, in their personnel, are themselves culturally diverse. And the community health worker has to navigate that as well. So the organization can have a culture, and it shapes it shapes what community health workers do, and it may at times clash with what they feel they need to do to be effective in the community. And then lastly, we all know this. If it wasn't recorded, it didn't happen. We've heard some comments about the importance of the ability of community health workers to interact with health records. But it is true that systems require reporting of results. They require reporting of interactions with the patients. And community, this is, I will say in fairness, this is, for many CHWs, this is not their favorite part of their job. They would rather be interacting with people. And the results of what they do may be less tangible. So it's incumbent on the organization to find ways of recording results. And there's some innovative work going on out there with, for example, tablet-based data entry that's based on menus rather than free text entry and so forth, that community health workers find more user-friendly. And there's a lot of creative work done on that. But one of the best practices that we've learned is that it's important for the community health workers to be involved in designing the reporting system that they're going to be accountable for, so that it makes sense to them, that the purpose is clear, and that it is user-friendly. So it's but organizational cultures and the culture of healthcare demand certain norms, and so it may mean that they have to learn new ways of expressing things in writing in a brief fashion. Also, and I'm sure community health workers like Lucia can relate to this as well, that the community health worker needs to be prepared in a team meeting to be very succinct about their observations about the patient and their suggestions. And that most community health workers, many of you will recognize this, are great storytellers, but the free-form telling of a story from the community doesn't always fit in the format of a team meeting, which most of you know can be very just the facts and very brief, and you have 15 seconds to say what's most important and then move on. So there's this is an important consideration in preparing the community health worker and the team for their presence in the work environment. So I will, on that, I will turn it back over to Jeff.
Thank you very much, Carl. And I think this last presentation that Carl has made is particularly important to emphasize that when Terry talked earlier about advanced planning and systems change, these adjustments are not just incumbent on the CHW. These are not things that the CHW should have to accommodate to the organizational culture, but that for planning effective integration, the organization needs to take these potential culture clashes into account in making systems level change. So let's hear about this at the ground level, a real organization. And Lucia, why don't you take us into your work at Rochester Regional in more depth?
Sure. So I have the pleasure to talk about Rochester Regional Health and our Community Health Workers program. I have to say that I'm very proud to work for this organization because I feel that they are fully committed to this integration, and in addition have provided a lot of support to our team. But it's not just because of community health workers. I think that we are moving more into the model of population health, but they have recognized the importance of community health workers. So I work for Rochester Regional Health, as I mentioned, and we are quite a large organization. We have 5 hospitals, and we served the community as a truly integrated health service organization. We have labs, we have behavioral health services, we have medical care for the homeless in the community, and many, many sites across the Finger Lakes region. We serve families and communities in Western New York, and there's quite a range of services. We also offer a wide range of services, and we have 28 federally qualified health center sites that provide dental care, primary care, OBGYN, and there's a lot of resources, but there's also a lot to learn because our CHW program really has been fully integrated with all of these services. So it has been a unique experience, and at the same time there was a lot of learning involved and a lot of collaboration so that we can truly provide a well-rounded source of resources for our patients. We also are a district project, so our organization is participating in 11 of the district projects funded through health transformation initiatives, and we actually have a lot of collaboration with the other projects. So as we move forward with some of the initiatives that the other projects are putting in place, they also are reminded that we have the patient activation program with the community health workers. How can that kind of affect some of the stuff that we're doing with behavioral health, or how can that affect some of the stuff that we're doing with housing? And so that has been extremely important for us. Integrating CHWs into services is one of the main components for us. So we work for the patient activation project, and we have a very specific target population. However, it actually opens up the doors for us to target patients who are not being touched by anybody else. So for example, self-pay. So we identify patients who are not linked to services, medical care, but also don't have health insurance. So we have identified a model where if someone comes into the emergency department, they get linked with health insurance, but also they could potentially become involved with community health workers so they can continue and find primary care services that they need so that it doesn't just stop there. And so we focus primarily on self-pay, Medicaid, low utilizers or non-utilizers of services. So our main focus really is to look at social determinants of health and work with those patients so that they can become engaged. If they don't have the services in place, then we walk them through the process. We make sure that they are going to their primary care services if they have not been receiving medical care. So our project really touches a lot of different points, and one of them is the outpatient model. So we have those federally qualified health centers. We started to work on a team approach with the population health model. So I have a couple of champions that have actually pulled me under their wing and have started to implement some of the changes around population health in nurse care managers and social workers. So they have done some restructuring around nurse care managers in clinical settings in regards to working with individuals that have high needs. And within that model, what they ended up doing is they went to the practices and they met with the directors and they met with their teams and their staff and talked about, okay, so we have these nurse care managers. How do we work and coordinate this services that we want to bring to you in addition to what you already have, such as the social workers, the nurses that are already there, and the doctors. And so what they did is they said, okay, so we're going to also bring community health workers so that as we're presenting this, we're also presenting the community health workers. And so that was key for us in kind of creating this integration, because at the beginning I was actually having a hard time just trying to connect because we're so large, right? It's all about building relationships sometimes. So we have the outpatient model, and we have integrated actually 3 community health workers into these clinics, and now they have allocated space. We made sure that the providers and the directors and everyone kind of got to know the community health worker. We're still working on promoting the services and still kind of figuring out who you're going to do, the roles, because we have also, in addition, health homes care managers. So we want to make sure that we're very clear about what it is that we're able to do. In addition to the outpatient model, we also have the ED work that we have been doing, because most of the work where we started to conduct the initial screening for our patients was in the emergency department. So currently we have 4 emergency departments where we are conducting screenings. We use the PAM as an initial screening tool. And what that does is basically gives us an opportunity to meet patients that are considered to be low utilizers, non-utilizers, or self-pay, that we can begin to establish relationships. So obviously we want to decrease ED utilization for those that perhaps just don't have a clear understanding of, well, I can go to urgent care versus going to emergency department, and looking into the reasons why someone would prefer to go to the emergency department versus their primary care doctor. So once we get connected with that patient, we talk to them about, tell us what are some of the barriers. It could be that that person works and that provider doesn't have open slots during the after hours. So we talk about, well, can we find a provider that offers you the time frame that you need so that you can feel comfortable going there for treatment versus going to ED. And at the same time, we're also encouraging to build those relationships with the providers. So in addition to the ED model, we have the inpatient model, which is something that I think it's a little bit more complex and that I'm still learning about. But what that means is we have patients that have been staying in the hospital for different reasons, right? So some because they have the medical conditions, they're not medically ready to be discharged. But at times there are some patients who really are lacking resources or additional support. And a community health worker could potentially be the key to work with some of those patients. We currently have been receiving some more referrals, but at the beginning it was a little bit of a challenge to become part of that complex care work group because, as Carl mentioned, it is more about just the facts, and we have a lot of patients that we need to talk about, so we have to kind of move it along. And I do agree with you that we do tend to do storytelling because I am a storyteller myself. But little by little, as we had more of a presence, as we had champions there, such as some of our directors that kind of formally introduced us, and actually we started with a handful of referrals. And once we proved that we were successful at engaging those patients and that we brought something unique to the table, now we're being included more and more in regards to, well, let's not forget we have community health workers. Maybe this is a different approach that we can present to the patient that can be helpful. So those are some of the things that we have been able to do. So like I said, the outpatient model, the inpatient model, and also the ED. In addition to that, we also are doing a lot of community engagement. So we are going into different settings to talk about the medical services that we offer, but it's not just about promoting the services. It's really, truly trying to find out what some of the barriers are for individuals to engage in their own medical care and to become more involved in their medical care and to feel empowered to build on those relationships with their primary care doctors. And so in doing that, we're also bringing that hospital component out into the community, and we're able to explain community members more about how they can utilize some of the services that we have, in addition working with other resources in the community. We have a strong relationship with some of our homeless shelters because we have a clinic mobile unit that goes over there, but also because we have high ED utilizers who actually live in those shelters. So the collaboration has to be strong, and I feel that the relationship of the community health workers who are able to go into those shelters, who feel comfortable going into those shelters, who feel comfortable talking to those patients, that has actually made a difference in regards to the collaboration between the hospital and those organizations. So that's some of the stuff that we have been able to do internally. We still have some more work to do around integration. The majority of the work that I have done is really building relationships so that I can provide a clear understanding of what community health workers bring to the table, who we are, what's unique about what we bring. And at times I have been challenged and asked about, well, should we have, a different model? Should we have social workers instead? And I think people also get worried about the medical ability for us to have some boundaries around what we're able to talk to patients or not. And what I can say about that is that actually we're more interested in making sure that that patient gets the best information from those professionals. But that sometimes that patient leaves that office without a clear understanding of what was said to them. And we have an opportunity to go back and make sure that that patient fully understands, or at least, we coach around or we provide additional information for them so that they understand what was said. So in addition to that, one of the things that we have been also working on is continue our collaboration with community organizations. We have an agency currently that we're working with in the rural area because they are truly the experts in the rural area. We want to make sure that our community health workers are fully integrated with them as well so that they can also be able to provide that linkage to those services for our patients. And I think so. Some of the challenges that I talked about with integration within the hospital setting, I think, is that there are different jobs titles of community health workers. So, for example, an organization that has outreach workers, and maybe they're integrating or they're trying to come to an appointment with their patient, it might not be clear that role of that worker is a CHW. And I think it also does create confusion, and that's the reason why we have to constantly keep explaining who we are and what we do, because there is a confusion around the scope of practice for community health workers because of the different titles that we have. Now, the different professions, I think, it's something that, for example, the champion person that we have in a team, in a leadership role, who is a nurse care manager. he really understands community health workers and really wants to support this effort. But if we have to work with another group who doesn't understand, it just takes a little bit longer to kind of move through that integration process. And we certainly value the partnerships that we have with the different organizations because, as I explained before, and I gave you the example of the shelter, those partnerships are going to be key in us moving forward with patients once they leave the hospital, right? Because they're going back into those communities. And so investing the time to form those partnerships is really, really important. On that note, I'm going to pass it back to Jeff.
Thank you very much, Lucia. This is really, really helpful. We had a question arise in the chat box while you were presenting from Kathy Karsting in Nebraska, who says, I sense a real disconnect between expectations of professional written and oral communication styles which require preparation and training and the life experience we value in CHWs. Could you, Lucia, describe the preparation and education requirements of CHWs at Rochester Regional Health?
Sure. So when I came on board, actually, we had a job description that was similar to another position that we had. And I kind of struggled with that because I wanted to make sure that it was accurate. In the educational requirement that we have is a high school diploma but years of experience, or an associate's degree or years of experience, and a bachelor's degree and years of experience. So the way that we have it set up is that we can hire someone with a high school diploma, but they have to have years of experience, right? Or we can hire someone with a bachelor's degree with less years of experience. But I think the difference is also that they get placed in a different pay rate. So not pay rate, but they get placed at a lower pay rate, and that's because as a large organization, they kind of have to match the other jobs that are within our system. So I think that was one of the difficult things for me. However, I have a great relationship with HR and with my business partners. So we spend a lot of time talking about how we can improve that. And also I talk to them about, I really want to hire this person, and I feel that they have the requirements that we are looking for in regards to life experience. How can I move forward with this? And we have been successful at doing that, but it took a little bit of work. Right now, I'm currently in the process of updating our job descriptions, and I'm also going to submit another proposal that's going to look at recruiting community health workers potentially at a different level. But, people want to get paid well as well. And we can't just rely on that educational background because then you're not placing value in their life experience. So I think that's one of the challenges that we're still kind of working towards, but I feel like at least for me, I have a little bit of flexibility.
Thank you. That's great. There are, of course, many examples of effectively integrated care models within organizations and teams. Carl's going to briefly describe a couple of additional ones. We will do our best to compile some additional resources that may be posted on ASTO CHW website, and then we'll move into a few final questions and opportunity for discussion. Carl?
Sure. Thanks, Jeff. So I'm going to just talk briefly about a couple of examples, and this first one, some of you may have heard of Spectrum Health. It's a large system primarily in western Michigan, and they have a program that has actually won awards from the American Hospital Association. The core health program is somewhat separate from their core operations. However, this is, and I believe this is as some health systems have their community benefits program set up as Spectrum is a nonprofit, that they have their community benefits program set up as a separate semi-autonomous organization. And so it is staffed by teams of nurses and community health workers, and it has shown some remarkable results in helping people to attain better degrees of control of chronic conditions. And the system, however, works on the basis of referrals from elsewhere in their system. So it's not truly integrated in the sense of the sort of ideal models that we have talked about, but it is producing some very positive results. The other one, which is much more of a textbook example of the kind of full integration, real integration that we've been talking about, it's been around for about 10 years, Bronx Lebanon Hospital, and they started, as many programs do, under grant funding, but the results were so positive that they made a business decision as a hospital to bring this in-house, to mainstream it, so to speak. And eventually it became supported out of operational funds. There is no dedicated funding stream, say, from Medicaid or from a health plan, but they have simply made the business decision, as some hospitals have done, including some here in Texas, to essentially allocate funds from within their overall operational budget with no dedicated funding stream. And now they have 35 of these community health workers. They have provided and have learned how to do this quite well, training for their clinical staff on how to work with community health workers. And as we've alluded to in a couple of occasions here, the community health workers actually present cases for discussion by the team at their team meetings. We have heard some anecdotal reports from these from this program within Bronx Lebanon that the clinical staff were wary of it initially, but have become kind of dependent on it. So we've heard stories, for example, of in an outpatient setting of a patient coming in for an office visit, the physician showing up at the exam room and seeing that the community health worker is in conversation with the patient, have actually excused themselves and said, "No, you need to complete this conversation. I'll come back again when you're ready." So deferring, in effect, to the value of the communication between the community health worker and the patient. And there are a number of these kinds of programs now around the country, not really identifiable as programs, I guess you would say, but organizations that have made it part of their operations, in which the providers now consider this to be indispensable. And there have been testimonials saying things like, I don't know what we would do without our community health workers, and things like that having the community health workers part of the team makes me a better physician, because it allows me to focus my expertise and to have a clearer picture of what's going on with that patient in their life. So it's this has been a shining example. We several of us know folks who were part of the starting of the beginning stages of this process at Bronx Lebanon, and I think New York Presbyterian is moving in the same direction in New York City. So there are many examples like this, but these stand out. Both of the examples that I've presented, by the way, we have some direct exposure to, but they were written up in a study on integration of community health workers published by the Commonwealth Fund, which we will give you directions for downloading. It is a very useful study, I think. So, Jeff, back to you.
Thank you, Carl. While you've been talking, Julie Chatil has asked, is there any movement towards national certification of CHWs, such as CHESS or CDEs? Those are all nationally certified instead of each state creating its own rules, which I think somewhat leads to the rules being unclear. So the quick answer is no, there's no national certification of CHWs. There is an initiative well underway to develop a National Association for Community Health Workers, of Community Health Workers, and that organization may take some role in vetting certification programs and establishing standards. As it stands now, the CHW Core Consensus Project that I mentioned earlier, the C3 project, which many of you will be familiar with from previous webinars, is providing a very valuable national starting point or frame of reference for common definitions of CHWs and CHW roles and skills. So we will make sure that you have the C3 reference information and link for those of you who are not familiar with it. We have time probably for one or two questions. If you want to hit *1, we'll open the lines again. Any questions for Lucia, particularly about the work that she just described, or anything else that we've been talking about?
And as a reminder, that is *1 to ask a question. And again, if you are on a speakerphone, please make sure that your mute button is disengaged so that your signal can reach our equipment. Once again, that is *1 to ask a question. And we have no questions on our roster at this time.
Okay. Well, I think then we will start to wrap up. I just want to thank you all again for participating. We've had almost everybody who started is still with us. We hope that this has been useful to you, both in providing a framework for thinking about integration and the various ways and domains in which integration is happening, the value of integration, some principles for integration in organizations and teams, and then some operational steps and guidance that can be used. I want to thank my colleague presenters, and particularly Lucia, for joining us in discussing the experience at Rochester Regional Health. I want to thank ASTHO and HRSA again, and turn this back over to Anna from ASTHO to wrap up.
Thank you very much, Jeff, Carl, Lucia, Terry. Everyone's contact information is available on the screen. If you think of any questions or need further guidance on any of the issues discussed today, please feel free to reach out to our team or ASTHO. This call has been recorded, and we'll be sending out a copy of that recording and the presentation slides to you. And we also have other resources available on ASTHO's website. So thank you very much for joining today, and enjoy the rest of your day and week. Thank you.
And again, ladies and gentlemen, this will conclude today's conference. Thank you for your participation. You may now disconnect.